who is also one of the few who didn't do all of his training at the Cleveland Clinic. So he actually completed his psychiatry residency at Massachusetts, at Mass Gen and McLean Hospital before doing a couple of fellowships, one in addiction psychiatry at Partners and another fellowship in forensic psychiatry at University Hospitals in Cleveland. And so we are grateful that he has seen the light and joined the Cleveland Clinic after that. And so we are grateful, too, that he decided to agree to come speak with you all. And so without further ado, Dr. Barnett.
All right, good afternoon, everyone. Today I'm going to talk to you about psychiatry cases that I hope are useful and are things that you encounter frequently in clinical practice. I'm a co-director of the Psychiatric Treatment Resistance Program at Cleveland Clinic, and so I spend the majority of my clinical time treating patients with pretty refractory mental health conditions, often mood disorders, and they usually have complex comorbidities, including neurological conditions. These are my disclosures here. Really the only thing that's relevant is I'll be talking about esketamine, and that's manufactured by Janssen Pharmaceuticals, and I've done some consulting work for them. So I'll cover three cases. The first of these will be depression in a patient with multiple sclerosis, then a case of a patient with Tourette syndrome who also has OCD, and I'll wrap up talking about psychosis and Parkinson's disease. All right, so we'll get into the first case here. The patient is Miss J. She's a 38-year-old woman. She's got relapsing remitting multiple sclerosis, had it for several years, and over the past couple of years, she's been noticing some significant changes in her mood, feeling sad for long periods, having trouble experiencing joy when she's doing things with her family or hobbies that have been stimulating before. She's tired a lot of times, spends a lot of time in bed, struggles to get up the motivation to clean the house, take her kids to activities after school. And it's hard to concentrate as well when she's reading, watching TV. She's found that she's really entered a period of indecisiveness in her life. So it takes a long time to make even basic decisions. So this is a treatment history that's pretty typical for what we see in the clinic where I work. So she's tried a couple different SSRI antidepressants, venlafaxine, and SNRI antidepressant, bupropion, mirtazapine. So antidepressants from several classes that have not been helpful. She's also done a fair trial of cognitive behavioral therapy. She's also had a tricyclic antidepressant and an MAOI antidepressant, and often the challenge with those medications is that they're harder to tolerate, though sometimes more effective than the other antidepressants that we have. But these weren't particularly helpful to her, and she had a lot of tolerability issues. So when I'm seeing a patient like this, this is sort of my broad approach. I'm a big fan of measurement-based care, so using some sort of validated instrument to screen for things like depression, anxiety, and to follow the patient's progress. I also ask about the timeline of their depression. When did this start? How many episodes have you had? Sometimes that can be useful for differentiating unipolar from bipolar depression. People with bipolar depression, they often have depression that occurs earlier in life, so in their teenage years or early 20s, whereas unipolar depression usually hits about 25, 26. And if they tell you they've had a lot of episodes of depression that are relatively short, that can also indicate bipolar disorder as well. The challenge with bipolar, which I'm not going to talk too much about today, but some people can go 5, 6, 7 decades after having a depressive episode and not have their first manic episode. So you can essentially treat them their whole life for unipolar depression and totally miss the bipolar element. Part of the work that I do is making sure that bipolar hasn't been missed. Of course, you want to ask about current stressors, see what's going on in their life that could be contributing to this, talk about past medications, how those were tolerated, get a sense of this person's relationship with suicidality. Have they had attempts before? Do they have a history of self-injurious behavior? That might tip you off to a diagnosis of borderline personality disorder, which can be pretty common in patients with treatment-resistant depression. And of course, if they're currently suicidal, that's really going to change what you do. You might be thinking about inpatient psychiatric hospitalization or getting them into a very rapidly acting treatment, such as esketamine or electroconvulsive therapy. You want to screen for trauma. If somebody has PTSD, often the depression will be unremitting if you're not really treating the underlying trauma with trauma-focused therapy. Also screen for substance use disorders. There are a variety of substances that can induce depression, and the substances themselves can also interact with antidepressants to reduce their efficacy. And then finally, you want to go over their non-psychiatric medical conditions, because sometimes people can have things like vitamin deficiencies, hypothyroidism that can cause depression as well. So this is a PHQ-9. We give this to every patient who sees a mental health provider at Cleveland Clinic. It's relatively easy to use. It's 9 questions that focus on the core symptoms of depression. And it just asks about the frequency. You total that up, and you have your score. When you're seeing a patient where you're considering depression, there's a standard laboratory workup that you should consider. I have to say, probably 99.9% of the time, all these results come back normal. So it's usually not helpful, at least directly, but I do find that some patients find it reassuring when they question the depression diagnosis. They want they want something quantitative in front of them to show them that you've thought of other potential causes. This is in line with what I said before. You're basically looking for things that could cause depression. So you're looking at the thyroid, looking at vitamin levels, checking RPR. I have to say I've only seen one case of syphilis-induced psychosis actually in the U.S., so you don't get a positive on that too many times. And then, of course, check for alcohol and drugs. Drug use is very, very common in our society now, and I've seen many diagnoses missed because providers are not aware of patients using heavy amounts of marijuana and alcohol. Many patients are totally unaware that it's very unusual to be having several drinks a day, and so there's still a lot of education within our society about what is actually a healthy level of alcohol use. And I strongly recommend using the PEth test if you have any worries here. If you're not familiar with that, it's basically like a hemoglobin A1C for alcohol use. So it can tell you kind of how heavily someone's been drinking in the past few weeks. So it's a really nice option to have, especially if somebody's binge drinking and they come in and they haven't had anything lately. But then you can look back and see that they've been drinking quite a bit. So for this particular patient, laboratory workup's normal, except for low vitamin D. That's basically every patient we treat in Cleveland. And so you treat that, doesn't affect the depression though. PHQ-9 score is 22, so that's consistent with severe depression, which would be a score of 20 or higher. There's no evidence to indicate bipolar disorder, personality disorder, substance use disorder. So this patient has treatment-resistant unipolar depression. And once you get to that stage, typically, as long as a patient has also tried psychotherapy, the remaining options are pretty much interventional. So ECT, transcranial magnetic stimulation, S-ketamine or IV ketamine. And treatment-resistant depression is surprisingly common. So it's about a third of patients with depression. And there's, of course, as with everything in psychiatry, there's debate within the field. But for the most part, there's agreement that if you've had 2 failed trials of antidepressants at adequate dose and duration, which is typically like something between like 6 and 9 weeks, then you meet criteria for treatment-resistant depression. And this is something that the field's trying to really raise awareness of, because essentially what that means is if you fail 2 antidepressants, it's sort of a waste of time to keep trying other ones. So the response rate and remission rates are pretty low. You can see the remission rate in this population is about 13% if you're just working with oral antidepressants. Now, you can get some improvement, augmenting agents like antipsychotics and that sort of thing. But really, if somebody has treatment-resistant depression, you need to be talking to them about the interventional options as soon as possible. And so, first one of these is tried and true ECT. ECT it's a very effective treatment. Unfortunately, there's a lot of stigma associated with ECT. From Hollywood depictions, One Flew Over the Cuckoo's Nest. I found now that most trainees have never heard of One Flew Over the Cuckoo's Nest. So I think we're kind of moving out of that phase of history. So people are like forgetting this negative depiction of ECT in Hollywood because the movie's so old now. It was a great movie though. I just wish they sort of left out that he got a lobotomy right after the ECT. So that's why he looked like he did, not the ECT. But ECT today, it's a very kind of routine procedure. Anesthesia is in there with you. The patient is under the entire time. They're only under for a few minutes. They usually bag them. They don't even intubate them. And your goal there is to use electricity to induce a seizure, so the patient's not aware of this. It's not painful. You try to get a seizure that's 20 seconds or longer. If it goes to about 2 minutes, then we'll give them some sort of benzodiazepine to stop it because we don't need the seizure to be longer than that. And they get the treatment. So the acute series is 9 treatments. It's 3 times a week for 3 weeks, 4 weeks. They're encouraged to stay on their medications. Sometimes patients ask us, since I'm getting ECT, does that mean I could just stop these medications? And we say, no, that's a bad idea. There really does seem to be synergistic effect with the medications that they're on. So we tell them to stay on their medications, and if they're going to come off them in the future, come off very slowly. And if a facility has the means, then we encourage tapering of ECT after the acute series. So you're giving them a few more over the ensuing weeks to months. But many times there's more demand than capacity, so patients will just stop after completion of the acute series. But a good number will need to come back for maintenance ECT. And that's because about half of patients relapse within 6 months, unless they're getting maintenance ECT or continuing medicine like lithium or something similar that's been shown to reduce the relapse risk. So the response rate with ECT and treatment-resistant depression is it's quite high. So it's 2/3, and compare that to what I showed you before with the low numbers for oral antidepressants. It usually only takes a few weeks for this to kick in. I mean, usually after maybe like the 4th or 5th ECT, we really start to see improvement. Families notice improvement. The ECT tends to work better in older patients, those with more severe depression and those with depression with psychotic features. There's no absolute medical contraindication for ECT, so we can essentially do it on anyone. But of course, there are conditions where we're going to stop and really weigh the potential risks and benefits. This is particularly in cases where people have lesions inside the brain, or they have cardiovascular problems. The other one, which I don't think is listed here, that I've seen sometimes is patients with severe epilepsy. So they can still benefit from ECT, but if it's really severe, then their neurologists will say, it's probably not worth the risk to come down on their anti-seizure medicines because they could have a serious seizure. So that's really kind of the only cases where I see where we don't move forward with ECT. And importantly, pregnancy is not a contraindication. And there are some centers that really specialize in ECT in pregnant women. And some women prefer this because you're not exposing the fetus to any sort of pharmacological agent for the depression throughout the course of the pregnancy. Adverse effects. So I will say most patients who get ECT have some sort of adverse effect. For the most part, these are minor things like headache, muscle pain after they've had the seizure, nausea with the anesthesia. Older patients can get confused sometimes as they're coming out from the anesthesia. A little bit more than half get anterograde amnesia. So it kind of presents the same way over and over. The patient will come and say, yeah, I had this conversation with my partner over the weekend. And then I had it with her again like 4 times, and she kept saying, why are you talking to me about this again? So try to give them a heads up that they might have conversations over and over and forget them. And that typically only lasts a few weeks after the ECT is over. And when they've done kind of longer term studies, memory is actually improved in patients after ECT after a few months because they're relieved of that cognitive impairment from the depression. And you can also get retrograde amnesia. That's pretty rare, but like you wouldn't want to take your kids to Disney World or something like the week before you get ECT because you're probably not going to remember that. We have patients wear a bite block so they don't get tooth damage during the seizure. Rarely you can get seizures outside of the ECT treatment period. Then, of course, there are the risks that are associated with anesthesia, but they're not any higher than any other procedure that requires anesthesia. All right, so on to TMS. So ECT is great. One other thing I forgot to mention is patients can't drive afterwards, so somebody has to come pick them up, which tends to be kind of the most complicated logistical factor that we have to deal with. There was obviously a need for an alternative to ECT, and so this led to TMS being developed. TMS, instead of using electricity to induce a seizure, it uses electromagnetic induction to induce the current in the specific areas of the brain for the condition that you're treating. So there's a coil that's placed near the patient's head. We use landmarks on the skull to identify where to place that coil. And for depression, for example, we're really trying to target the dorsolateral prefrontal cortex. And conventional TMS, this was a challenge in the past. The sessions were 20 to 40 minutes. You have to do them basically Monday through Friday for 6 weeks. Now we use theta bursts more commonly, and so those sessions are just 3 to 5 minutes. So honestly, it takes more time for the patient to get parked and get checked in than the actual treatment. Still, they got to come, every day, 5 days a week for 6 weeks. So that's the big challenge. But there are research protocols that are looking very promising where patients can get all that TMS just crammed into a few days. And so we're very excited about that. I think that really could be a game changer for psychiatry. There have been several clinical trials looking at TMS versus sham TMS, and it looks like TMS is about twice as effective as sham. And so this is not something where, I think it's primarily placebo effect. This has been repeated, in multiple populations now. Maintenance is important. I would say this is kind of the biggest challenge that we have with TMS is that, it's similar to ECT. Patients do well, most of them respond, but then after a few months, people start to relapse, and so the remission rates and response rates are higher if you're getting maintenance, and that typically is like maybe once a month. The problem is, insurance coverage. There have not been enough large trials for the insurers to get on board with paying for maintenance. Now, clinically, it's very apparent to us that patients need maintenance, but still waiting for more big trials looking at maintenance so that insurance coverage will improve. So it's typically very well tolerated, so you're not looking at the cognitive issues that you get with ECT. You're not dealing with anesthesia. Patients can drive afterwards. Sometimes their scalp might burn a little. They might have a headache. Very rarely seizure can occur, and we try to avoid this in patients with implanted devices that are close to the coil. Generally, we avoid TMS in patients with seizure histories, or if they're taking medications that might lower the seizure threshold. If they've had severe head trauma, stroke, brain tumor, we'll avoid that as well. All right, so on to esketamine. So this is the newest item that we've had added to our list of possible treatments for treatment-resistant depression. So it's been FDA approved maybe for 5 years now, and so it's been a nice addition to the field, but it's taken a long time to roll it out because it's pretty logistically intensive, and so there's still a lot of patients who have not had access to this yet. So it's approved by the FDA for treatment of treatment-resistant depression and major depressive disorder with acute suicidality. It works really quickly. Patients can feel better even starting with the treatment or a couple hours afterwards. It's very expensive. It's still branded. You're going to get prior authorizations. There can be a lot of challenges with that. It's not FDA approved for bipolar depression, and so that's been really unfortunate because those patients often have very difficult to treat depression, and they don't have access to this. Right now, patients have to be on an oral antidepressant because clinical trials have shown that esketamine works better in combination with an antidepressant. And this does alter consciousness, so there's a pretty strict REM system to reduce misuse, so it can only be given at a healthcare facility, and patients can have dissociation, so they're monitored for 2 hours, and they also can't drive afterwards. And I just want to point out, I'm talking about esketamine here because it's FDA approved for treatment-resistant depression, but we have many trials now showing that off-label use of ketamine is also effective for treatment-resistant depression, and it's just been sort of an unfortunate accident of history that we can't use ketamine more. So the patent for ketamine expired, I think, somewhere around 2002, which is around the same time that the field really became aware of the antidepressant potential of ketamine. So there's no financial incentive for a company to take ketamine back to the FDA now and get an indication for treatment-resistant depression. So there's lots of ketamine out there that's available, but insurance won't pay for it. So patients have to pay between $500 and $2,000 an infusion, and that'll give you antidepressant relief for maybe like a week or two on average. And so unless you're very wealthy, it's not worth it. And so that's sort of the advantage of esketamine. There have not been head-to-head trials yet. We have suspicions that IV ketamine might be a little bit more helpful because we can go to a higher dose. But the real advantage with esketamine, well, I guess there are two. So one is that it's intranasal, so the nurses aren't having to get IV access on patients every time they come in. They can take care of more patients at once. And then the other one is insurance coverage, which is actually pretty good. All right, so we really try to optimize the setting when patients are getting treated with this. Esketamine, it's a ketamine derivative, so it's a hallucinogen, so it has, for some patients, psychedelic effects, similar to psilocybin or LSD, so it can be, pretty intense experiences. There's been decades of observational data suggesting that the setting actually influences the psychoactive effects and possibly the therapeutic effects. And so there are clinical trials that are just starting to look into this now. But generally, we tell people to wear eye shades, to listen to curated music lists that are like kind of specially designed to track along with the intensity of the experience. And we have recliners for them. And so that's definitely the most optimal way to do this treatment if you have a space available. This is the standard treatment regimen, so patients will get it twice weekly for a month and then go into maintenance if they respond. So they'll get it once a week for a month, and then after that, you try to spread them out to every 2 weeks if possible, or they can stay at every week. But there are now 6-year safety data showing that it's safe to continue these patients on maintenance, and most of them are going to need maintenance treatment too. High rates of response, more than half of patients remit. However, as I said, similar to IV ketamine, the effects wear off relatively quickly, and so most patients are going to need maintenance. In contrast to ECT, this tends to work better in younger patients, patients who are employed, who have structure, something to wake up for each day. It also works better if they have not failed many antidepressants, and we don't know whether the multiple failures is just indication of more severe depression, or if there really is sort of a negative effect of being exposed to antidepressants for long periods that might make your depression harder to treat. So this is a big question in the field. And then if you respond, by the end of the first week, odds are you're going to respond at the end of the treatment course. And like I said before, it works better with an oral antidepressant. Most common adverse effects are dissociation, which most patients actually don't mind. Nausea, vomiting, I would say that's probably the most problematic one. There are pretty predictable increases in blood pressure and heart rate. I've never had to treat anybody for this. We typically expect it and watch it come down by the end of the treatment, but rarely patients do need treated for that. There is addictive potential, so we're careful in patients who have substance use disorders, and it also has the risk to cause hypomania or mania in patients with bipolar, similar to oral antidepressants. Generally, if you're in good cardiac health, you don't have any liver problems, and you don't have any bladder problems, since repeated exposure to high-dose ketamine can cause cystitis, then we'll treat you. We do tend to avoid it in patients with psychosis, but not necessarily if they've had psychosis in the past, but if they have a psychosis in a current episode, we're probably not going to use it unless there's really extenuating circumstances. All right, so this patient got referred for TMS, unfortunately didn't respond after a 6-week acute series, was referred for esketamine, responded to that, did their acute series, and this is also not uncommon here. They're feeling great. They say, I'm all fixed now, and then a week or two later, they say the depression's back and they have to go on maintenance. So we try to give them a heads up that most patients are going to need to go on maintenance. And then as an aside here, there's a lot of ketamine research in areas outside of psychiatry, and some growing interest in using ketamine to treat multiple sclerosis-related fatigue. So I think based on this study here, there's an even larger study that's underway right now. So pretty exciting times for ketamine research in a variety of domains. All right, so on to the second case, OCD in a patient with Tourette syndrome. Mr. Y is 28 years old. He's had Tourette syndrome since he was 7 years old. He's got motor, vocal tics, reasonably managed with clonidine. The problem is this ongoing OCD. I'll just quickly review the diagnostic criteria for OCD here out of the DSM. The first one is presence of obsessions, compulsions, or both. Sometimes some patients only have obsessions, and the OCD diagnosis gets missed because they don't have the compulsions. But obsessions, are these recurrent, persistent, intrusive thoughts or urges that cause anxiety and distress, and the patient will, attempt to ignore these or suppress them. And then compulsions are repetitive behaviors that the person feels driven to perform in response to that obsession. So it helps reduce the anxiety associated with the obsession. These are things that they have to either be time-consuming or cause really clinically significant distress or impairment in some domain of life. So if somebody's spending an hour or more on this, and that's generally seen as pretty problematic. I see lots of patients who say, I check the door 3 times at night to make sure it's locked or something like that. So not really OCD. It's kind of an OCD trait, but not something that we're going to treat somebody for. All right, so by the age of 13, he developed OCD, primarily involving intrusive thoughts and compulsive behaviors around religious purity, moral correctness. So this is like a pretty textbook case of what we call religious scrupulosity. So obsessions about having committed a sin or inadvertently doing something that's sacrilegious, thinking about going to hell a lot and eternal damnation, those sorts of things. Compulsively prays to try to deal with this. Frequently confesses, what he thinks are the sins that he's committed to religious leaders and family members. Constantly looking for reassurance that he hasn't done anything sinful. And this is pretty time consuming. Repeating these prayers over and over. So the patient is withdrawn. He's not able to maintain his employment because of this. So it's really getting in the way of his life. He's had a number of medication trials. So with OCD, we need to go above. We often need to go above the FDA approved maximum dose for antidepressants. And so, for example, sertraline it's 200 milligrams, fluoxetine it's 80. So this patient here has had appropriate trials of high dose SSRIs that haven't been that helpful. He's also done CBT with exposure and response prevention, and so that's a particular type of CBT for OCD that also is only partially effective. He's done fluvoxamine at high dose, had some nausea with that, and then clomipramine, which is still considered the gold standard treatment for OCD. So it's a tricyclic antidepressant with a lot of serotonergic activity. And the challenge with clomipramine is tolerability. So patients often do get things like constipation, dry mouth, drowsiness. All right, so this brings us to our first self-assessment question here. So what proportion of patients with Tourette syndrome also develop obsessive compulsive disorder during their lifetime? So we got A 10%, B 20, C 30, D 50. All right, so the answer here is D actually. So it's a really high rate of comorbidity, more than 50%. And so the only psychiatric condition that has higher comorbidity is ADHD, and women are more likely to have comorbid OCD with Tourette's than men. All right, so the diagnosis here is SRI resistant OCD. So there are augmentation strategies that we use. We'll add the things listed there on top of an SSRI or clomipramine, and so it's kind of a varied group of agents: antipsychotics, memantine, NAC, riluzole, and then there's also TMS. And for very refractory cases, which we do these at Cleveland Clinic, is deep brain stimulation. Which on average reduces their OCD intensity by about 50%. So it can be a really, really helpful treatment. But obviously, we try everything before we get to that point. You can also do the fluvoxamine clomipramine combination therapy. Because of pharmacological interaction between those two drugs, it actually lets you use a lower dose of clomipramine, so the side effects aren't as problematic for patients. And then, kind of the one big thing that we look at when things have reached this level is we make sure that the patient has actually had adequate ERP therapy. Because many times when you review the records, they've done therapy that really didn't focus on doing exposures to help them with the anxiety related to the OCD. And so sometimes, we'll ask patients to go see another provider to get more intensive ERP. All right, so this patient, this is not uncommon. The patient says, I'm tired of feeling like a guinea pig. I don't want to try all these medications, lots of frustration. And so he wants to try TMS. It turns out TMS can be very, very helpful for OCD. It's actually a different coil than the one that we use for depression. So it's called the deep coil that reaches deeper structures related to OCD. And so this patient got TMS and responded well, but similar to depression, maintenance is often required. So this patient required maintenance. All right, so final case here: psychosis in a patient with Parkinson's disease. Mrs. R, she's 75 years old. She's had Parkinson's for more than a decade. She also has depression, anxiety. She's been having progressive motor symptoms, but getting reasonable relief with levodopa, carbidopa. And over the past year, she's been developing psychosis with visual hallucinations and paranoid delusions. This is a pretty typical kind of presentation for Parkinson's psychosis. So she worries her husband's hiding another woman in the house. There's often this visual hallucination component. She sees soldiers standing out on the porch, wondering whether they're going to take her away. And so that's one thing that kind of makes Parkinson's psychosis unique from something like schizophrenia is the visual hallucination component, since schizophrenia is primarily auditory hallucinations. But obviously these symptoms have been problematic for her, but also her husband, and really impacting both of their quality of life. There's no evidence of dementia, which is something you got to think about in cases like this. She's tried a couple antidepressants for her depression to see if maybe it was depression with psychotic features, but that didn't really affect the psychosis. She's tried quetiapine at low dose. That's typically what people will use to treat Parkinson's disease-related psychosis. But she had sedation from that, orthostatic hypotension, didn't really help very much. Risperidone was tried, not something I would recommend. Kind of predictably, she got worsening of Parkinsonian symptoms. These are her current medications. Oftentimes these patients are actually dealing with iatrogenic psychosis from their medications, since we're using dopaminergic agents for the motor aspects of the Parkinson's. So she's on several agents here that have potential to be causing or worsening the psychosis. So amantadine has some dopaminergic activity. The carbidopa, levodopa, pramipexole, dopamine agonists, the rasagiline, MAOI, so it's going to increase dopamine levels as well. So there's a few other things to think about in terms of what might be going on here. Is there Lewy body dementia going on, or some other type of dementia? If this was kind of more acute, you think about delirium. We talked about depression with psychotic features before. Is this sort of a late life onset of psychotic disorder or bipolar disorder? That's very rare, and oftentimes it means something vascular is going on. Is there substance misuse? Maybe not something that we thought about as much before, but now we do see significant amounts of substance use in older patients who've been using for decades now. Thyroid dysfunction. So this patient, the examination doesn't show delirium or mania. MoCA looks good, so there's not really evidence of dementia. Mood symptoms seem well controlled. It's really the paranoia and the hallucinations that the patient is most perturbed by. Laboratory studies don't show anything revealing, nothing new revealed by physical examination. A couple things here. It could be the PDP, could be medication-induced psychosis, and so you want to systematically work to simplify the medication regimen and remove any medications that might be contributing to the psychosis. And so typically starting with the non-Parkinson related medications, and then reducing the anti-Parkinson medications to the lowest dose possible, or discontinuing them in the order there. So anticholinergics, MAOIs, amantadine, dopamine agonists, COMT inhibitors, and the carbidopa, levodopa. With this patient, the changes to the medication regimen didn't really improve the psychosis too much, and trying to get rid of the carbidopa, levodopa really worsened the motor symptoms. So everything was removed except for that. And this brings us to our second question here. So in the management of difficult to treat psychosis in patients with Parkinson's, which medication is often considered despite the need for regular blood monitoring due to agranulocytosis risk? All right, so most people are aware that that monitoring is required for clozapine, and so clozapine is used much less frequently as a result, which I think is unfortunate. I think the FDA's really missed the mark with the REMS requirements for agranulocytosis and clozapine, because we use a lot of medications in medicine that actually have the same agranulocytosis risk, and so it's actually been pretty pretty reassuring to see that the FDA is now, they're actually meeting this month to reconsider the REMS system for clozapine to see if they might ease those restrictions some. And so I hope that they do, because it's taken a lot of lobbying by a lot of people to get them to take a second look at that. Like in other countries like China, clozapine is the first line medication for schizophrenia. And so we're just way too conservative about that risk. All right, and there's the reference there. So essentially in a case like this, you've got two choices. You've got clozapine or the newer agent, pimavanserin, which is a 5-HT2A antagonist and inverse agonist. So it doesn't do anything to dopamine directly. So there's an advantage there for patients with Parkinson's, spares them the movement worsening. Clozapine, still has some other challenges besides agranulocytosis. When you're starting it, there's a risk of cardiomyopathy. It can cause pretty significant constipation and ileus. It has a higher seizure risk than other antipsychotics. It can make patients very, very tired. Can cause sialorrhea, pretty profound weight gain. And then pimavanserin has a much better side effect profile, as you can see there. All right, so this patient here, I think the logical next step is to try the pimavanserin. They had partial improvement in their symptoms, but not complete. The family's still looking for more. So you do a cross titration with clozapine, and the psychosis is getting better, even better than it was on the pimavanserin. But once a dosage of 50 milligrams a day is reached, a patient can't tolerate a higher dose due to orthostatic hypotension. And also getting some side effects, sialorrhea. We'll often use sublingual atropine drops for that. One option here is to actually add the pimavanserin back and use the clozapine in combination. Sometimes you can get much better results doing that. So this particular patient had a complete resolution of symptoms. So the main takeaways here are, there are multiple options for a patient like this, and sometimes if the clozapine doesn't work, the pimavanserin will, and vice versa, and sometimes you need to use them both in combination. So it's nice to have that option now. All right, so these are my final takeaway points, and I'm happy to take your questions. So if you are seeing patients in your practice who have treatment-resistant depression, really encourage them to talk to their mental health provider about interventional psychiatry. And, sometimes you get, a mental health provider who's, pretty conservative and is not referring patients out for these treatments. And I would just say encourage the patient to go around their provider and contact the TMS centers or esketamine centers directly. That's happening a lot now. I think it's going to take, kind of years for these treatments to disseminate down within the field so that psychiatrists are referring appropriately. And so sometimes the patients just have to take matters into their own hands and go directly to one of these centers. Remember, TMS can also be helpful for OCD if you have a location in your city that has the deep coil. Not all locations do. And then, with refractory Parkinson's disease psychosis, just remember that you can combine pimavanserin and clozapine. And that's it. Thank you all. Yeah.
I had read, and it was also at a consult I had placed for some help with the patient, Parkinson's psychosis. And maybe I misunderstood, but the answer that I got was use of ribostigmine. Did I misunderstand that? Is that being used at all?
So, sometimes the cholinesterase inhibitors can be helpful, but that's generally if there's dementia at play. And so, that's not something that I would, kind of reach for first unless I thought that there was a dementia element. Yeah.
I've been using pimavanserin first and not using Seroquel or risperidone in Parkinson's patients. So I don't know, is that how it is out there? Or?
I think that's great if you can. I know sometimes there are insurance challenges because it's a newer drug, but if you're getting coverage,
That's the actual MD indication. So
Yeah.
in terms of actual approval, you just have to get a pre-auth and you're done.
Yeah. Sometimes they have prior authorization requirements. They've tried other things, but I think why take the risk with Seroquel and its dopaminergic action if you can just avoid that altogether.
I mean, I have got the pre-auth approved, so I'm not in denial. So we have to do the paperwork, but we do get the authorizations.
Yeah. All right. Great. Thank you.
All right, so we're going to be on break now. Thanks to our last two speakers. We have 2 more talks to go, so we will reconvene here at 2:40 p.m. on the dot. So enjoy some coffee, water, use the restroom, and visit the sponsors, and we'll see you back.